Hi everyone. Okay, so I wanted to do a quick review to cover Afib, cardioversion versus defibrillation. I called this cardiac rhythm management because that is a title used in the industry in cardiac care. It includes pacemakers, ICDs, biventricular pacers, and ICDs. For testing purposes, there is information assigned in your reading about all these, but this review is going to focus on Afib, cardioversion, and defibrillation because it's assigned your reading, but the important things to learn about out of this is the Afib, cardioversion, and defibrillation. Okay, so we already talked about sudden cardiac death at the end of the ACS lecture. We know that the rhythms involved with this are ventricular fibrillation, that's the lower strip, and symptomatic VT. Symptomatic VT is ventricular tachycardia without a pulse. So you can have ventricular tachycardia or runs of ventricular tachycardia, and you can be just fine because you still have a pulse and are perfusing. No pulse with ventricular tachycardia means that you have to treat it just the same as ventricular fibrillation. We know that ventricular fibrillation is chaotic and it is not a perfusing rhythm. So if these things occur and the patient's usually in the hospital, when this is the situation I'm talking about, you need to check for responsiveness and feel for a pulse. You need to call a code. You need to begin CPR. Then when the team arrives and a defibrillator is there, they apply the patches and a shock is delivered if these rhythms are seen while analyzing. Just like you learned in CPR, apply the patches and it tells you to wait and analyze, and then it will tell you to deliver the shock. The shock of electricity with defibrillation is a higher energy shock than with cardioversion. So this shock is called defibrillation. It's most effective when it happens within the first 2 minutes of the dysrhythmia onset. The electrical shock depolarizes all the cells in the myocardium, and hopefully the SA node can resume being the pacemaker for the heart. This picture shows the actual paddles on the left picture, and in most settings you're probably not going to see that. You're going to see the AP for anterior-posterior patches being applied to the patient, just like you learned in your CPR class. So for those black and white thinkers, yes, we call them AP patches for anterior-posterior, but they are often applied in many different ways, not purely anterior and posterior. The point is to sandwich the heart within them so the electricity flows. You see the dotted lines kind of showing the electricity flow through and across the heart from the top patch across to the bottom patch. So if it's applied purely anteriorly and posteriorly, where one's patch is in the front, maybe right over the center of the chest, and the other one is on the back, kind of center of the chest of the back, that's still going to shoot electricity across the heart to hopefully reset it to allow that SA node to work. You know that when you do your CPR class and you practice those simulations, that the CPR pads have the pictures on them, where to place them, and that's basically what you need to know. I'm just trying to point out they're called AP patches, so you know what they're talking about in the hospital. Sometimes our terminology doesn't always get explained. Basic defibrillators are gonna deliver these shocks, defibrillation, like I said before, at a much higher energy than the synchronized cardioversion, which we're going to get to next. Okay, so synchronized cardioversion, it's going to be used for ventricular tachycardia without a pulse, with a pulse. So this is the VT, the ventricular tachycardia that you can see, and the patient's still there talking to you. They might start to have some problems, like they may be a little dizzy, they may be a little bit lower blood pressure. They're not compromised greatly hemodynamically just yet, and they're still talking to you and aware of the situation. Also, it's used for supraventricular tachydysrhythmias. In this case, I'm mainly telling you for Afib. atrial fibrillation with a very rapid ventricular response, which means that they're not going to be very hemodynamically stable, because with AFib they're going to have lost that atrial kick that they get from getting the atrium both filled evenly with normal sinus rhythm. So it's used for synchronized cardioversion is used for VT with a pulse and for rapid ventricular response atrial fibrillation. So that means our ventricular rate on the AFib is pretty fast. Okay, so most patients are going to get sedation for this synchronized cardioversion, and there's going to be advanced practice providers like an NP or the MD. Sometimes anesthesia is there, depending on the patient history, and trying to sedate somebody who has, a lot of comorbidities is going to be a lot more tricky, where they might want anesthesia for certain patients instead of just a nurse giving sedation. They're going to use the same kind of defibrillator that they would use to deliver the shock for ventricular fibrillation, but this time what we're going to do is we're going to set the device, or set the machine, the defibrillator machine itself, to be in the sync mode. So what that means is the shock is going to be delivered in a method that is right on the middle of the QRS or just after the peak of the QRS, and not on the T wave. We want to avoid ventricular fibrillation, and if you put the shock on top of the T wave, that makes ventricular fibrillation. So in the strip that you see here, the starting where it says charging to 100 joules, that looks to be ventricular tachycardia, just from me looking at it by sight. Whether it is or isn't, that's not the point here, is that they chose to synchronize cardioversion this patient. So you see those little arrows or triangles on the top of each QRS. That's the device is on sync, and so that it's watching the rhythm and making the mark on top of each of those QRSs, so it can tell where to deliver the shock. And then you can see shock delivered, and then you see one beat, and then you see kind of a pause, and then you see what looks like pretty much normal sinus rhythm, maybe some ST depression. We're not really taking apart this rhythm to look at that. Just you see that now there's a P, a QRS, and a T wave after that shock. So that's pretty cool to see what it really looks like for synchronized cardioversion. Also, the joules are a lot lower, so the energy delivered with synchronized cardioversion is a lower amount than you deliver when you're not syncing it and you're just purely defibrillating a big amount of electricity. It can be anywhere from 200 to 360 depending on your defibrillator for defibrillation. And for synchronized cardioversion, it's going to be, as you see, 70 to 75 joules or 100 joules, depending on what kind of defibrillator machine you have. Okay, so then the next strip, next slide is, I want to make some points about atrial fibrillation. It's the most common dysrhythmia. It occurs in 10% of those greater than age 80, and overall in 1% of the population will get atrial fib. The risk factors: hypertension, myocardial infarction. That's supposed to say heart failure, but it says HR. So let me just fix that now so this is ready for next time. Thank you. Obesity, alcohol use, smoking, obstructive sleep apnea, all those things are risk factors for atrial fibrillation. The patients are going to complain of palpitations, fatigue, tachycardia, weakness, shortness of breath, dizziness, and they might have an embolic event. That means clots have gone somewhere out of the heart and into the body system. So a stroke, pulmonary embolus, DVT, some kind of clot issue could happen with atrial fibrillation. And they might even have right heart failure. That's what RHF is. And they could have the, peripheral edema, ascites, weight gain with that. To diagnose it, we need an EKG, and they're probably going to get a TEE done. So that's a it should be TTE, transthoracic echo. That means on the chest ultrasound. If they can't see or something's really wrong, the patient's really sick, they might do the TEE, which is a transesophageal echo. That's the one where the probe goes down your esophagus, you swallow it, and it gives better pictures. They're also going to have labs drawn. You want to know where they stand as far as did they have an acute coronary syndrome event? Did they have renal failure? Are they having other issues where their chemistries are off, or an infection or something else to add to the complexity that a patient may present with, besides just the Afib? So the goals are going to be to resolve any hemodynamic issues that may be occurring. Remember, sometimes when people get atrial fib for the first time, it might be a really rapid ventricular response, and that can create hemodynamic issues where their blood pressure and body can't keep up with what the heart is doing any longer. So we want to control that heart rate. We don't want it to have that rapid ventricular response. We want to get them back to normal sinus rhythm or sinus rhythm. And we want to prevent thrombi formation. So you don't want to have them throwing clots all over and having those embolic events. So to treat, you're going to do synchronized cardioversion, especially for hemodynamically unstable patients that have that rapid ventricular rate like we talked about in the previous slides. If they've been in atrial fibrillation for 48 hours or longer, they're going to need 3 weeks worth of anticoagulation, which is warfarin or Coumadin, with an INR reading during that time. The beneficial reading needs to be between 2.0 and 3.0. So that's going to need to be done. If they don't come in and get checked right away, if it's been 48 hours or more, they're going to need to have that Coumadin treatment of 3 weeks before you do anything to correct that rhythm. Then they're still probably going to have a transthoracic echo beforehand to check for atrial thrombi. Okay, so then other treatment besides that is rate control, especially older adults who keep having atrial fibrillation, but they have mild symptoms. You might not want to shock them, and you might not want to give them, you might not want to treat them, with really aggressive treatment because they're older and they might not tolerate that. Rate control sometimes is just fine for them, and beta blockers and calcium channel blockers are used. Sometimes they're going to use IV or PO amiodarone, but not always. So just know that there's treatments there. The main thing is that you've got to think about the reason that they're making clots, and that's because if the atria are not squeezing, if they're fibrillating, the blood flow can pool and circulate in the atrium, and there's stasis, and so clots can be formed in there. And if you convert somebody to normal sinus rhythm without doing either the echo or the treatment with Coumadin to make sure that the clots haven't really built up a whole bunch of clots, you have the risk of causing the showering of clots. So you want to really be aware that one of the biggest problems with AFib is embolic events. That's all I have. I just wanted to make sure I covered these points thoroughly. It's in your book, but I just wanted you to know the treatment number 6 about the 48 hours or longer is an important one to remember. And thanks for listening, you guys. Bye.